Hello, my name is Holger Woehrle. I'm a German pulmonologist specialized in pulmonology and sleep medicine. I head up the Sleep and Ventilation Center in Blaubeuren, which is close to the city where I come from, Ulm, Germany, which is in the south of Germany. We're a large regional center for pulmonology and for sleep medicine. We'll take care of roughly 30,000 patients a year, have in our sleep lab per year roughly 2,000 to 3,000 patients overnight, and take care about 5,000 to 6,000 outpatients per year. My special interest is telemedicine, e-health, m-health, because we know that the new digitalization taking care in medicine will transform medical care dramatically in the next 5 to 10 years. Digitalization takes care in industry, so we're working with many partners trying to improve medical care throughout the world. So let me start by explaining to you the framework of e-health, which I think is very important. When we talk about telemedicine, everybody has something else in mind. So we always need to specify about what we talk when we're talking about telemedicine, which is part of a broad e-health application, which is now, I think, in addition with m-health, a complete network of digital solutions for modern healthcare. So when we talk about telehealth in sleep apnea management, we're talking about different fields. We already talked about telediagnostics. We know that there is, in some countries, remote sleep centers which are working in collaboration with, for example, general practitioners, and they get their, for example, overnight recordings referred to their center, and then they can either give to the local physician the results of their scoring, or they do a teleconsultation directly with the patient who is not living in that city. They can connect with the patient. What you could also think of is that you do teletherapy, that you set up a patient, for example, on a PEP therapy in a city where you don't have a specialized physician in sleep medicine, but you're connected with the patient, and you could do that through, I think, the topic that is the hottest right now in telehealth, which is telemonitoring. We've got the biggest area of telehealth worldwide in sleep medicine with PEP therapy. We've got millions of patients already being connected through telemonitoring with their sleep physician or their pulmonary physician. And we've got over 1 billion of nights already delivering data, which we can hopefully use in the future to improve the care of patients with sleep apnea. So why do we need to change? There is a very interesting study that was published just a couple of months ago by Adam Benjafield, which looks at global prevalence of sleep apnea. What the group has done, they pulled together all the sleep apnea prevalence studies from different countries, and what it shows that sleep apnea is very prevalent, and that is in contrast to the care models that we have in most of the countries, which are rather focused on a small proportion of sleep apnea patients. If you see, for example, for the country where I'm coming from, in Germany, we have 14 million patients who suffer from moderate to severe sleep apnea. With the current care model in Germany, where patients have to go for one night for PSG to get titrated on PEP therapy, it would take us 20 or more years to get all of these patients on therapy, which shows that we need new technology to help work with this big burden of sleep apnea in the general population. There is already development in terms of new technology that can help us manage sleep apnea patients already in terms of diagnosis. There's a new app which is called NOSAS, which was developed by Raphael Heinzer from Lausanne and colleagues, and it's already available on the App Store, and it's a very simple score, which we know normally works best for males rather than for females, but there is a very simple score encompassing neck circumference, weight, snoring, age, and sex. And you have a very simple score. If you're over 8 points in that score, you have a high pretest probability of having obstructive sleep apnea. And we know in patients with high pretest probability, at least, we don't need a polysomnography to confirm the diagnosis of obstructive sleep apnea. So already for diagnosis, we have tools available that can enable us to manage the disease differently. In addition, we know that sensors in the smartphones available, for example, the microphone can nowadays almost identify obstructive sleep apnea as well as a home sleep test. So I think we're going to see more developments in that field that will help us diagnose and identify patients in a much easier way than we currently do. The challenge of all medical systems currently who use polysomnography is that polysomnography is a bottleneck. We have to get every patient through a sleep lab, which leads to long waiting times and not optimal care, because we know that polysomnography itself is not leading to improved outcomes. So we'll have to think how to use new technology that we have for diagnosing obstructive sleep apnea to be able to treat more patients, diagnose and treat more patients quicker. If we go into CPAP therapy, next year or 2 years, we're going to have 40 years of CPAP therapy. And it's one of the best therapies available in internal medicine. It has improved millions of lives around the globe. And it's still a very simple therapy as it was when it was invented in 1981. It's a positive pressure applied to the upper airway that splints the upper airway. It's so easy. Current medical practice is not optimal because what we mainly do in sleep medicine, we identify obstructive sleep apnea, and if it's moderate to severe sleep apnea, we apply CPAP for everybody. But as with any drug, for example, it's the same with CPAP. Not all patients will benefit from it. And if we would have optimal medical care, we would identify the patients who can tolerate CPAP and will benefit from it upfront, which would be called precision medicine. And while we need precision medicine, you can also see in another new study that was just published by the Spanish group from Ferran Barbey, which looks at the important topic of blood pressure and obstructive sleep apnea and its treatment effects. Now we know from meta-analysis that CPAP therapy decreases blood pressure in obstructive sleep apnea. But this new trial shows when you differentiate the group of patients with obstructive sleep apnea in dippers, so in patients who still drop their blood pressure during sleep, although they have obstructive sleep apnea, versus the ones who don't dip, probably because they have stress of obstructive sleep apnea and the blood pressure stays up, we also get in these two different groups different responses. So what we get is in patients who are non-dippers, we get a marked blood pressure decrease through CPAP therapy. While in those who already dip, we can't improve the blood pressure. So there are markers that we can identify to tailor the right treatment at the right patient. And having said that the nocturnal blood pressure seems to be a target, this is very important because the elevated blood pressure at night is the highest risk factor for stroke. And there is new data after we had some not so good news for heart disease and CPAP therapy where we couldn't really improve outcomes. We think that the right target for PAP therapy is the brain. And we see here a cohort study, again from our Swiss colleagues, and they can show if we use CPAP therapy for the right patients, we can improve outcomes. If we take patients with stroke, so having a brain problem, and we treat obstructive sleep apnea, we can improve outcomes. Which links to the information that we've seen before, that if we decrease nocturnal blood pressure successfully with PAP therapy, we probably can link that then to improved outcomes. So we need the right treatment for the right patient. And that leads to precision medicine. That's the new goal of modern therapy. We're trying to tailor treatments to the right patients and get the right outcomes while having the patient participate in his therapy. That's the new paradigm. And what's important is that we also think about differential therapy for obstructive sleep apnea, which is nowadays more than just PAP therapy. The forgotten therapy in obstructive sleep apnea is weight loss, nutrition, and exercise. We know that roughly, for example, in Germany, 2/3 of our patients are obese, and if we drop their weight, we can improve their obstructive sleep apnea. But there's other therapies available. There is mandibular advancement devices, which work very well, especially in mild to moderate obstructive sleep apnea. There is hypoglossal nerve stimulation for those patients who can't tolerate CPAP. We know there's a significant percentage who just suffers from positional sleep apnea, which we can treat with positional treatment. And there are still available surgical procedures for specific patients, for example, with increased or with enlarged tonsils, or for patients with retrognathia, there are surgical opportunities. And although all of these don't work in the whole population, they might work on a specific subpopulation. And if we tell patients about their specific opportunities, they might engage more with the therapy than we choose for them because they know why this one works for them especially. So While going back to PEP therapy, we'll have to acknowledge that roughly after 10 years, half of the patients in recent years have stopped therapy. That's why we also need differential therapies. And on the other hand, we need to improve PEP adherence. That's an ongoing mission for all of us. And interestingly, although we got new technology, new masks in recent years, if we look at the nice analysis about the trends in CPAP adherence in recent years, we see CPAP adherence hasn't really changed in the last 20 years. Which might also have to do that we have better technology, we have better masks, but we're also treating more people. We're treating milder disease, we're treating less symptomatic patients, and that might have led to the stable adherence rates over the years. Again, which shows tailoring the right treatment at the right patients with the right support could improve outcomes. And I think that's where we need to get the help of digital technologies improving adherence, and by that improving outcomes. So what can we do to improve adherence? This is a study that we had done a couple of years ago together with a healthcare provider in Germany. We took patients who wanted to quit therapy, which, as we just have seen, occurs quite frequently. And instead of telling them, okay, you want to quit, you quit, we offered them a different mask. We offered them a nasal pillows mask. And what was surprising to us, about half of the patients who we saw or who consulted a healthcare provider were still using the therapy after 8 months, which shows if something fails in PEP therapy, that doesn't mean we stop. That means we have to offer other solutions. Another solution could be another mask. That's the example here. It could be a different device. We know that there are specific bilevel solutions which can also rescue therapy, because when the patient stops the therapy, he's lost in terms of therapy first. So we should all invest into offering different solutions in patients, try to either improve or just rescue PEP adherence. Already in 2012, when telemonitoring was introduced to the field of obstructive sleep apnea, there were trials showing that telemonitoring can support better adherence. In this study, they showed clearly that using telemonitoring to proactively manage the patient, so to consult him when you're seeing through telemonitoring that adherence is not optimal, and with that offering then help, like for example a different mask or a different device, can really improve usage and with that potentially outcomes. And the technology has really evolved. In the meantime, we have connected CPAP devices which give us access to the patient data, so we can check adherence as well as treatment quality, which means we can check leakage, but we can also check residual respiratory events through a web solution, which is called AirView. And so what we did when it was invented in Germany, we talked to our home care provider and tried to change the care model. The current care model was at that time what we called reactive service. The patient needed to experience a problem with his therapy, and then he needed to consult via telephone his healthcare provider. So what we tried to change is we said, when we see through telemonitoring, through the web-based platform, that patients are struggling using their therapy, they can't use it regularly for at least 4 hours per night, for a couple of days, we would consult the patient proactively and try to offer him other solutions, other masks, humidification, other devices, other pressures. And with that, we were able to dramatically reduce dropout in the first years. It's a matched cohort analysis where you see we had 3,400 patients in each group, and you could see that we, within 1 year, halved the therapy termination rate. And therapy termination is the hardest outcome because that means the patient actively returns his device. So we can use telemonitoring to change the care model, because telemonitoring itself doesn't make anything better. Just you see that the patient is struggling doesn't help the patient, but using the data to proactively support the patient with different technology or with different support mechanisms can make a difference. And then if we go back to the concept of precision medicine, very importantly nowadays, patients want to engage with their therapy. They want to participate with their therapy. An example is blood pressure management. Patients test their blood pressure, measure it at home regularly, and with that they engage with their medication, with their therapy. And we can do nowadays the same thing in sleep apnea, which is very important. We've got engagement tools that the patient gets a direct feedback from his therapy how well he's doing, which is very important for the patient. He goes home, gets a new therapy, a new mask, he changes his life, and for him it's very important in that situation to get a feedback. And we tested the application which is called myAir, where the patient gets every morning a feedback about how the last night was. It gives them a feedback on sleep duration, on also quality of respiratory therapy with residual events, but also on leakage. And what we showed in this publication that we've done in the Journal of Sleep Medicine a couple of years ago, we compared patients who had already proactive support, like I showed you before, and then the ones who got in addition the patient engagement tool. And what we could show, again in a matched pair analysis of 500 patients in each group, that we could really improve adherence. If you see, our goal is that the patient sleeps for the whole night, at least 5 to 6 hours with the device. And with the addition of the patient engagement tool, we were able to increase usage. So we've got a tool that engages the patient, what the patient wants, and with that we improve adherence, which is still our biggest goal in current PEP therapy management. The same analysis was done in a US population published by Atul Malhotra in CHEST. Same thing, comparing in that a large group of patients who had normal care models and a group with active patient engagement. They had a large group available through the web-based data, and they compared roughly 80,000 patients with the usual care model with roughly 40,000 patients with active patient engagement. And they found the same thing as we did. If you look at the graph here, you can see that with active patient engagement, you have a much higher proportion of patients using therapy longer at night, and with longer usage, with better usage, we know we can create better outcomes. So already 2 publications also showing how important patient engagement into therapy is. The other area where telehealth can play a major role is one of the challenges that we have when we're titrating PAP patients, which is central sleep apnea occurring during CPAP. First described in 2006 by the Mayo Group, it was shown that patients who present, like you can see here, with classical severe obstructive sleep apnea can develop, when they're being put on CPAP therapy, central apnea. And it's quite a common phenomenon that we see initially when we set up patients on PEP therapy. And it was also recognized by the latest International Classification of Sleep Disorder, the 3rd edition. We've got now the term called treatment emergent central sleep apnea, TEXA, which used to be called complex sleep apnea. So it's also been now recognized in the definition of the central sleep apnea syndromes. And what we learned already initially, it's a phenomenon that can just go away over time. It was already shown a year after description that in some patients this phenomenon goes away. So we just have to monitor it rather than treat it. And the reason for that is that it was already shown in the initial decade of obstructive sleep apnea research by the Colin Sullivan group, that your drive to breathe changes once you get on PEP therapy compared to before when you have obstructive sleep apnea. And with the change in your drive to breathe, central sleep apnea can diminish and can go away. So what is very important for that is that what we can already do right now is we have to look at device data. This is very important. Here is an example of a patient from our clinic, and you can see he had, when he was set up on PEP therapy, central apnea, but you can see it goes away. But where you have to look at is at the large variance in the follow-up. If you look, for example, on the 14th of September, he would have an AHI of 20. If you would do a home sleep test on that day, you would probably change his therapy. But the next couple of days, he's got an AHI of around 5, so you would continue therapy. That's why it's so important that we look at device data and not just at a one-night recording when we look at central apnea in PEP therapy. Here's a different example from a patient where you can see he had a combined problem of obstructive and central sleep apnea. He had renal failure. He was close to dialysis. And as you can see, under CPAP, his initial AHI was 80 something. And with CPAP, we could reduce it to around 40. Yeah, but it was mainly central. As you can see, in this patient, the central apnea didn't go away, although there is again a large fluctuation in AHI. And you can also see days where you might have not switched the therapy versus days where we would have clearly had an indication to change treatment. And we looked at that phenomenon in a big data set that we have from the AirView database. And we published over 130,000 patients. And you can see what's very important is don't look in the follow-up at a single day, look at the so-called trajectories of change. And what we could show as a first group is we have different trajectories of central apnea occurrence during PEP therapy. You have a group who's got obstructive sleep apnea, is well treated, and full stop, all good, managed adherence. But we've got a group who got persistent central sleep apnea. And we know that the persistence of central apnea is associated with increased therapy termination, probably also highlighting disrupted sleep. And there is a group where we've got a transient, so CSA goes away, as we just described before. But there is another very interesting group which has emergent central apnea. So initially, it rather looks good, but over time, over the first 3 months, they develop central apnea. So it's also a very important message. Just because having set up a patient successfully doesn't mean he's not developing central apnea over time. So we need to look at it initially, but also over time. And our recommendation is look at the device data and don't look at a single night, but look at the trajectories of change. And with that, we can phenotype the patients. So we'll get a group who's got persistent central apnea, which is quite common, which is a quarter of the patient. But we also have roughly 20% of the patient where central apnea emerges. So we have to recognize it because both phenotypes have an increased risk of therapy termination. So then we wanted to know what happens if physicians then change therapy. So apply for residual central apnea adaptive ventilation. And we did another big data analysis from the same data set. And we looked at what happens with those patients receiving then the right therapy with adaptive ventilation. And as you can see here, as we would expect, once changing the patients from CPAP to ASV, we get stable and good control of AHI, as we would expect. But what I mentioned is, managing adherence, optimizing adherence, as we could see, there are also trajectories of adherence. It's not enough just to look at average adherence. We have to look at the trend. And as you can see, the trend with CPAP was that adherence was diminishing, while with ASV, we could stabilize adherence. And with better adherence, our goal is to optimize outcomes for the patient. So that's where telehealth comes in. We can monitor the patients, we can identify the patients at risk, we can identify changes over time, and then we can take the right therapeutic decisions at the right time. And just to give you a heads up, the concept of trajectories is coming to pulmonary medicine. That's an example of FEV1, our most important marker for obstructive airway disease. And also there are now publications highlighting that the FEV1 over time is more important than the snapshot of doing one lung function. And also there, just to give you a vision of where pulmonary medicine overall is going, we'll get in the future digital spirometers, which will give us FEV1 over time. And the same thing that is currently already in place in obstructive sleep apnea or in sleep disorder breathing management with connected PEP devices will be available with connected inhalers. So we can also monitor adherence in, for example, obstructive airway disease. So it's not just a phenomenon that we're seeing in sleep apnea. We're just learning from sleep apnea for other important fields like obstructive airway disease. And I can tell you in the next 5 to 10 years, we're going to see many connected therapies, and sleep apnea will guide us the way how to deal with that. So hopefully I was able to show you that the future of respiratory sleep medicine is clearly digital. We've got solutions already right now facilitating diagnosis, giving us pretest probabilities that can help us do simpler tests at home to get more patients diagnosed with less effort, but also less costly. With that, we need to be able to treat more patients. We need to tailor treatment. We need to do precision medicine. And still the majority of patients will go on PEP therapy. But then we need to make sure that we support the patient right. We can identify patients at risk for low adherence with the help of telemedicine. We can try different solutions, different masks, different PEP devices. We can support the patients, and very importantly, we can engage the patients with new technology like patient engagement apps. I hope this is useful for your daily practice. Right now is the time to really make a difference to healthcare with the use of modern technologies. Thank you.